Thank you for inviting me here today. As Louise says, I'm a pharmacist and I actually work in Western Bartonshire, so I'm a prescribing advisor. And my role up until now has been traditionally working with GPs, practice nurses, district nurses, but increasingly with all non-medical prescribers, of which you are becoming a part. So I'm just going to go over a bit about the prescribing monitoring that we do and the governance that we've got around that. So what am I going to cover? I'm just going to cover the big picture with you, hopefully, give you an idea of context. Influences on prescribing. I don't know what you've discussed already this morning, but I was going to talk about the influences on prescribing, both the influences on you and why you prescribe what you prescribe, and also your influences on other prescribers, because you're already having an impact on other prescribers even now. And also I'll just give you some brief information about the types of prescribing information that we can get and the types of monitoring that we can do. Now obviously I work in Greater Glasgow and Clyde, so I have a very much a Greater Glasgow and Clyde bias towards what I'm going to say. However, people like me exist right across Scotland. Is everybody here from Greater Glasgow, or are we all over the country? Yeah. Anybody from England? Right. So there will be similar structures down south, but so forgive me for being very Scottish in what I'm going to talk about. But I thought, seeing as it was first thing after lunch, and everybody's always very excited to come back after lunch, we would start with a quiz, because that always makes sure that you're actually still awake. So it's a wee bit out of date now, but it's Who Wants to Be a Millionaire? And obviously, normally you would have your 3 lifelines. You would have your 50-50 and you have your ask the audience and phone a friend. Well, in this instance, it's me just asking the audience what you think the answers are, okay? So I've only got 3 questions, and I'm afraid I don't have a prize. Okay, so your first question, just about the context here. How much do we spend on prescriptions? Now, that's all the prescriptions in Scotland, and that was last financial year. How much money do we spend on prescriptions? Any ideas? A. A, okay. Any advance on A? All right, hands up everyone for A. Ooh, lots. B? Okay, C? You're a lone person, I'm afraid. And D? Okay. Well, you were right, £1.15 billion we spend on prescriptions. So we spend a lot of money on prescriptions, okay? Therefore, we're very interested in it, and you will contribute to that spend once you become IP prescribers. Okay, your second question. Eye products, specifically. How much, in the same time frame, do you think we spent just on products in the eye sections of the BNF? Again, anybody like to hazard a guess? B. B? I can tell you it's not A, okay? I'll give you a clue, all right? So, B, C, D. Over £13 million. And this is just primary care. This is just the GP, nurse prescribing, your prescribing. It's nothing to do with the hospitals, okay? So this is just in primary care. Okay, your third and final question. Of all the eye preparations, which one of those do you think that we spend the most on? It's actually relatively easy, I think, but what do you think? D. Yeah, you've got the most products in that area. Almost a quarter of the money that we spend on eye preparations is spent on lubricants, which is why there's so many of them. It's big business. Okay. So from my point of view, you've got 2 responsibilities as a prescriber. You've got the clinical responsibility to make sure that it's necessary, that the patient needs it, and that it's appropriate for them to get it. And you've also got the legal responsibilities, which I think you've already talked about today, in terms of it being a licensed product, etc., and the responsibilities you take on that. But from my point of view, you've also got the bigger picture here in terms of the financial responsibilities that you bear. You've got a responsibility to the taxpayer. In other words, to you and to me, to all of us who pay tax. Therefore, you're expected to be cost effective in your prescribing. And it's not just you, we're not singling you out. Every prescriber is expected to prescribe in a cost effective way. Now, please do not mix up cost effective with inexpensive. That's not what I'm talking about. We're talking about cost effective. Now, it might be that the most expensive product is also the most cost effective. But a lot of people get mixed up. When I talk about cost effective, they think all we're trying to do is save money. And in a sense we are, but it's about being cost effective. When you see how much money we spend, billions of pounds on prescribing, you know the times that we live in, that budget is being squeezed. They want reductions in that budget all the time. Every year we are asked to make savings on the prescribing budget, and therefore it's absolutely vital that we are cost effective in our prescribing. Prescribing should only be for what the patient needs, not necessarily for what they want. And it is quite difficult sometimes. You will get patients who will come in and expect to be prescribed something. As the clinician, you need to be comfortable that the patient really needs it before you prescribe it. I'm a prescriber. I'm an independent prescriber as well. I'm a pharmacist independent prescriber. And I do get patients coming in wanting various preparations. You have to be able to say, no, that's not what you need. Therefore, I cannot prescribe it for you. Okay? So what else can influence your prescribing? Obviously, patient expectation at the bottom there. They can come in expecting you to prescribe something. You gave it to my auntie, my granny, my friend, therefore I would like it too. But the auntie, granny or friend had one particular condition, you don't, and therefore it's not appropriate for me to prescribe this for you. Okay? But there's other things that will influence your prescribing. Where you practice. Deprivation will have an impact. Quite often it's in the more affluent areas that you get more demands for prescribing that might not be appropriate, rather than in the less affluent areas, shall we say. I have the joy of working in Western Berkshire, and I do actually like working in Western Berkshire, but it's definitely not affluent. So we don't have people generally coming in with things off the internet telling you what they want prescribed. The age of your population will also impact on what you prescribe and how much you prescribe. Because obviously if you've got a young student population whose main problem is just their eyesight, but their eyes are actually in very good condition, then you will not need to prescribe nearly as much as perhaps if you've got an elderly population that you're looking after. And as I said, patient expectations are a biggie. It's quite a difficult one. You don't want to set up patient expectation, that's another thing as well. And as I say, you should always prescribe for what the patient needs, not necessarily for what they want, although in this case, the patient's family didn't necessarily want it. What else can influence your prescribing? Well, things like this will influence your prescribing when you're at educational events, journals that you read, secondary care, so your colleagues, if you work in secondary care, that will influence your prescribing. If you see prescribing coming out of secondary care, that will influence your prescribing. Guidelines, where they exist, they should be influencing your prescribing. You might have a specific area of interest within optometry where you want to prescribe. And when it comes to monitoring of prescribing, from my point of view, or for people like me, when we are looking at your prescribing, and we will be looking at your prescribing, sometimes that can cause problems, because we'll see what we think is an outlier, somebody who is prescribing something unusual, not normal. Everybody else is over here, we've got one person over here. So we'll come and ask you about that. And that's fine, because you'll explain it's an area of interest, or I've had specialist training, and that's why I'm prescribing in that area. And we get that with GPs as well. All prescribers we get. All the district nurses, they only virtually prescribe dressings all the time. So all they're prescribing is dressings, and then occasionally we'll get antibiotics. So we'll ask them, well, why were you prescribing the antibiotics? Because that's not really generally their area of expertise. Habit. I'm a prescriber. I generally prescribe about 3 different things. I have a habit. As long as those are cost effective and correct for the patient, well, that's absolutely fine. You get comfortable. You know what those preparations will do. You know how they're likely to react, how the patient's likely to respond to them. So you do get into the habit of prescribing things, definitely. But the one area that we do get influenced by, even if we don't realise we're being influenced by it, is the pharmaceutical industry. And if they haven't already started targeting you, they will. because they see you as an opportunity. It's a different set of prescribers, somebody else that they can influence, and they're very good at it. Okay? They're extremely good at influencing people. For example, here's an advert for Losec. It came out early 90s, and it's nothing to do with eyes. I couldn't find an eye one. It's to do with acid. PPI. It's a PPI. It's to do with acid in your stomach. It revolutionised treatment for ulcers. Fantastic drug. Really, really good. They had a fabulous advertising campaign. Within 2 years, 6% of the NHS budget was being spent on that drug. And that was mainly to do with the advertising. It also helped that it was a good drug, and therefore it was useful and people did use it. And we still prescribe a lot of it today, although we now prescribe the generic version. Are you familiar with generic and branded products? So I don't need to explain that, and that's fine. So we still spend huge amounts of money, but instead of it being £30 a box now, it's a few pounds a box, because it's become generic. The last influence on your prescribing, hopefully, will be people like me. So if you don't work in Western Berkshire, you won't come across me. But there are people like me in every area of Glasgow, and there are people like me right across Scotland. We might have slightly different titles or slightly different names, but basically we're prescribing advisors, we have different titles, but basically we monitor prescribing all the time. And as your numbers are increasing, we will be concentrating on you a little bit more than we have done up until now. And our aim as a sort of team is to promote the safe, clinical, and there's that word again, more words, cost-effective prescribing. And we work with prescribers. So like I say, I work with GPs all the time. They phone me up all the time. I've been asked to prescribe such and such. What do you think? Or I've got a patient here who's got such and such a condition. What would be the best preparation for us to try? And like I say, cost-effective doesn't mean least expensive. But what about your influence on prescribing? Now, I suspect that most of you in this room here at some point have seen a patient and then wrote a note to either the GP or the pharmacy or wherever saying, I saw your patient today, they have X condition, please could you prescribe? Would that be fair to say? Yeah? And that's what's happening. And I know it happens because I see it in the practices that I work in. So I picked 2 preparations. This is Greater Glasgow and Clyde data only. I went back to April, June 12 because that's when Optive Plus was launched. Neither of these preparations were on the Greater Glasgow and Clyde formulary. Therefore, there was no pressure from sort of people like me for these things to be prescribed. And yet look at the growth, in particular of Optive Plus. Now that's all pretty much come from either secondary care or yourselves recommending it and the GP's just writing the prescription. Now, there's nothing wrong with that. I mean, you're the first port of call for eye preparation, so, eye treatments. We encourage the GPs to send people to you. However, Clinitas and Optive Plus weren't our formulary choices. So what I would be saying to you is that when you're prescribing, we would be expecting you to pick the formulary choices, at least first. And if it doesn't work, fair enough, you can then move on to other preparations. But you can see the huge growth there. Now you're going to say to me, I know that that's gone up, but hypromelos will have come down. I'm aware of your issues with hypromelos and the fact that you don't see it as being the most ideal eye drop. So in an ideal world, as that's going up, the hypromelos will be coming down. Well, it isn't really. There's a bit of seasonal variation. It goes down in the winter, January to March, but pretty much it's still climbing, and that's the same time period. So this is additional prescribing, okay, rather than replacement prescribing. But really what I'm trying to show there is that, pressure on prescribing can come from you guys already, whether you write the first prescription and ask the GP to continue it, or whether you do what you're doing just now. Now, remember how many millions we spend? If we have a 1% increase in costs, that's a lot of money. Okay, so again, it's back to what patients need, not what they want. Cost effective. Because unfortunately, we can't afford everything for everybody. We have to be frugal. Why do I monitor prescribing? Well, this isn't to do with you, obviously, but one of the main reasons we monitor prescribing is because of waste. There's lots of it. There's estimates around that 10% of every prescription, or 10% of the prescriptions that are dispensed, end up in a cupboard and never get used. Think about how much money that is if you've got a budget of billions. So we try to make sure that people only get what they really need, so that they don't fill up their cupboards full of stuff like that. And we see it all the time. And if you're like me and used to work in a community pharmacy, the black bin bags full of stuff would come back from people's houses all the time. Or you'd go in and you'd open the cupboard and 6 boxes of Fibogel would fall on top of you because they just don't take it anymore. So that's one of the reasons we try and monitor prescribing. How do we do that? Well, we have lots of ways of doing it. And we've not really got into gear with you guys yet, but it's coming. But with the GPs, we give them indicators. We give them targets. We ask them to prescribe in a certain way, and then we compare them. We compare them to their peers. We compare them to Glasgow. We compare them to Scotland. And if they're outliers, we go and we speak to them and we ask them why they're an outlier and ask them to change their practice to bring them more into the way everyone else is prescribing. We do a lot of analysis and we do some audit. And I think that for you as prescribers, you should be auditing your own prescribing. So why did you write that prescription? Why did you pick that particular preparation? If there is a guideline, did you pick the guideline preparation or did you not? And if you didn't, why didn't you? Is there something you need to change about your prescribing? It might be absolutely fine. You might audit your prescribing and decide that you actually are working completely appropriately. And again, that's just good to know. And if possible, you should be sharing that at peer review type sessions, speaking to your colleagues, seeing how they're prescribing as well. We also provide education to the GPs. So we'll pick an area. On Monday, I'm doing a session with one of the practices around antibiotics because their prescribing of antibiotics is an outlier. It's higher than all the other practices in the area. So we look at that and we think, well, the population isn't that significantly different for that practice compared to all the other practices in that area. So why is your antibiotic prescribing double? So we go in and we examine and we try and get them to come up with the reasons. I can tell you what the reason is because they don't bother seeing the patient, they just issue a prescription on a phone call. So I actually already know what, but we have to go through that process to get them to understand that A, they're very different from everywhere else, and that the myths they have about not prescribing as much, or that the fact that all the patients will shout at them and all these things, are not strictly speaking true, because their colleagues in the same building across the corridor don't prescribe like that and don't have those issues. Okay. There's non-medical prescribing groups certainly within all the areas of Glasgow, and if you are in Glasgow and you get a pad in Glasgow, you will be expected to join our non-medical prescribing database so that we can tell you about things that are happening. A lot of it will be irrelevant to you, but there will be bits and pieces from time to time that will be of use. And we also do some sort of local work. So I actually see patients in practices, so the patients will come in and we'll do what we call a polypharmacy review, where they're on several medicines and we'll go through them all. Do they still need them? Are they still appropriate? Are they causing them any side effects? Is there something better now? Because the guidelines have changed since they were started. Do they not need something anymore? Can we stop it? But basically, Big Brother's watching you, or will be watching you. Okay? And if you're in Glasgow, that's me. Because although I work in Western Bartonshire, I actually have a responsibility for optometry prescribing for the whole of Greater Glasgow and Clyde. So for Greater Glasgow and Clyde, I'm leading on that, and I'm also working nationally as well. So I suspect that what we're doing in Glasgow will end up happening across the rest of Scotland. Okay? How do we actually do the monitoring? Well, that's a publicly available website, ISD. Have you all heard of ISD before? It's Information Services Division of National Services Scotland, and it provides all the data. So you'll see news reports from time to time saying X number of heart attacks have happened or Y number of people have stopped smoking. It's ISD that provide that information. And when you write a prescription, do you know what happens to it after the person takes it to the pharmacy? No? Well, I'll tell you then. So you write a prescription and it goes to the chemist and the chemist dispenses it. Twice a month they send those prescriptions off and they end up in Edinburgh and they get priced. That's how we know how much has been spent, and the pharmacy gets reimbursed for the cost of the medicines. Okay? And all that information goes onto a big database. And we can interrogate that database. Now, that database is confidential and only certain people can interrogate it. So people like me have permission to go in and look at these things. The public website will only give you the big numbers. So those numbers that I used in the quiz, they all came from that public website. So you can go up and check to see I've done it right. I wouldn't bother, it's not very exciting. But if you really wanted to, if you want to be as nerdy as me, then you can go and look at that, okay? But I can get much more detailed information. In fact, I could get, if you write a prescription, within 3 months, I can actually get a copy of that prescription back. Okay, so I can actually go and say, I would like a copy of that specific prescription. If you write a prescription for something unusual, and I get a scanned image of that prescription back, front and back, see what was written on it. Okay, and we do that from time to time. We don't do it very often, but we do it from time to time. Because sometimes there's mistakes made. On our database, it says there was 10 bottles of hypromelos dispensed, and we think, 10? What do they need 10 for? And then you get the form back, and it was actually one OP, one original pack, and it's been misread as 10. So mistakes like that will happen. So we'll get it back and we'll check, and then we'll get it corrected. Okay. So that's the public website, and if you're really keen, you can go and have a look at that. If you just Google ISD, it'll come up. Okay. But because I've got access to this big database, this specific database, we can pull off specific prescribing information. Now, this is a prescribing report that we've been developing within Glasgow, and I've anonymised it, but it is for a genuine prescriber, optometrist prescriber within Glasgow. And basically what we've done is we've gone away and we've looked at that person's prescribing between January and March this year. The other thing I need to say is that all our prescribing information is 3 months behind. It's always 3 months behind, because it takes a while for the prescription to get to Edinburgh to be scanned in and to be priced, so it takes a while. Okay? And so we can tell what you've prescribed, how many of them you've prescribed, how much it's cost. An item is, if you write 2 things on a prescription, that would be 2 items. The quantity is the number of bottles or whatever that you've prescribed. So you could have 1 item for 2 bottles, or 1 item for 1 bottle. And then you've got the GIC, and GIC means gross ingredient cost. In other words, how much is it? How much did the NHS pay for it? Which can be different, and will be different, from the price that you would charge somebody if you were selling them it. Okay? It's an agreed price, an NHS price. And what I haven't shown at the bottom there is we can then go on to analyse, in terms of our preferred list, in terms of our formulary in Greater Glasgow, how many of those items were formulary items, how many of them were non-formulary items. And we can do a percentage calculation. So in this particular instance, 80% of that person's prescribing was within the formulary, which is what we would expect. In fact, even higher. Okay? And this is the kind of thing that we're developing at the moment, and like I say, I'm working nationally, so I suspect that this kind of report will be done nationally. And the intention is that at least once a year, IPs would get their own report. They would get their own information sent to them, and it would give you an opportunity to do audit, because what we're planning to do is to give you some comparison data for other IPs in your area. What are they prescribing? Is it similar to what you're prescribing? Okay? Why do we worry about it? Well, apart from the fact there's lots of money involved. Well, there is lots of money involved, so the Scottish Government are very interested in what we're doing. With Audit Scotland also looking at prescribing from time to time. In Glasgow, we have these things called organisational performance reviews, where we are measured on our prescribing. We share data, like I said, so that we can compare and contrast to see whether we're outliers or not. The thing about prescribing is it's very variable and it's very volatile. We've got no direct control over you guys. You've got a prescription pad and you can write. If it's allowed on prescription, you can write it. And so can the GPs, so can the pharmacists, so can the dentists. But as I've said, a 1% shift in the budget can make a huge difference to the costs. So you're all independent, you're all out there working. We've got very little direct control. In fact, we've got no direct control over you. So we need you to be on side with us. We need you to understand why it's important that you keep in mind that big picture. Okay? And we want to get the best value for money for everybody, for all of us. So I'm back to cost effectiveness again. Sorry to keep going on about it. So I've just got a wee example of cost effectiveness, and hopefully it's not in your slides. We tried to keep out the ones that were interactive. So the cost is how much we pay for it. The effect is obviously what it does. And cost effective just means good value for money. So I've got another question for you. Okay, we've only got £1,000 to spend. And we've got a certain condition that we're trying to treat. Pick any condition you like. We've got 2 drugs, one of which shows a 96% efficacy and one that shows a 90% efficacy. But one costs £10 and one costs £1. Which is the most cost effective? It's not very difficult, I hope. B. Yeah. So if I was sitting in the formulary subgroup, picking a formulary drug, I would go for B. Why would I go for B? Because for my £1,000, I could have 900 people treated, as opposed to only 96 people if we pick drug A. Okay, so for 6% of the population, drug B isn't going to work. And for those 6%, we'd give them drug A. But we get much more value for money. And that's the way formularies are looked at and are created. And you should always use the formulary choices as a first line. And I know for a certain percentage of people it will not be the right thing and it will not work, but for the vast majority of people it should be. Okay? We also have what these things called quality prescribing measures that we give to the GPs, and in time we probably will give them to you as well. So antibiotics are a big thing. There's a lot of emphasis on antibiotics at the moment because of problems with C. diff and MRSA. I'm sure you've seen it in the news. So there's a lot of concern about the volume of antibiotic prescribing out there, and especially at this time of year as we start to go into flu season and everybody gets the cold and everybody wants antibiotics. And that's why I'm doing a session with the GPs on Monday, because we're coming up to the peak time for prescribing. So we expect everybody who is a prescriber who may prescribe an antibiotic to think about antimicrobial stewardship, as they talk about. Okay. And the ones there, the antibiotic items and the DDDs of quinolones, DDD means a defined daily dose. So for each type of medicine, there's this defined daily dose, and it's actually the World Health Organization who decides what a defined daily dose is. So for Losec, omeprazole that I talked about earlier on, the defined daily dose is 20 milligrams a day. And so we compare, and these are national indicators. We have these things called national therapeutic indicators. And again, we compare the GPs with each other. There is a body called the Scottish Antimicrobial Prescribing Group, or SAPG, as it's affectionately known. And it produces all of these indicators, and it looks at all the prescribing, and it gives guidance about how antibiotics should be used within Scotland. And so we'll be expecting you to stick to the guidance, if there is any, and the formulary. Formulary, you talked about formularies already today, is that right? Yes? No? A little bit? Okay. You know what a formulary is then? It's a list of medicines. In different areas, they have slightly different ways of laying them out. Some areas just have a very limited list, and that's their formulary. Okay. Other areas, including Glasgow, and I'll show you that in a minute. I put my teeth back in. Have sort of a two-tiered formulary. One we call the preferred list, and then the sort of everything else that we would still suggest you could prescribe. But for an awful lot of areas, it's like they just have a very small list, and they basically expect 80% plus of your prescribing to be from that limited list. And like I've said, these are the cost-effective preparations that should work for 90% of the people, therefore you should be able to use it most of the time. It does all the work for you, as we've described. It uses the evidence-based guidelines, and we are very much into evidence-based. It promotes the cost-effective use, and it is about maximising what we've got. Sometimes you'll see it'll be in there, but there'll be restrictions on it. Only to be started by an ophthalmologist. Only to be used in hospital. Specialist use only. They have different ways of saying it, but basically there are certain drugs where they really only should be started by a specialist. They should minimise the risk because we should have the information about their safety. And in terms of cost, especially in hospitals, they can get special prices sometimes. The drug companies will sell them at special prices. So if it's in the formulary, then it maximises the amount of money we can save within the hospital sector. The Scottish Medicines Consortium, has anyone ever heard of that? SMC? Yep. So the equivalent body in England would be NICE. They talk about that quite a lot in the news. SMC has been going for, I don't know how many years now actually, and they basically look at all the new drugs that come out. Now, the companies are required to make a submission to SMC. And if companies do not make a submission to SMC, it will not be recommended for prescribing within Scotland. End of story. However, if the company does make a submission to SMC, it will be looked at. It's not about safety at this stage. That's already been done by the licensing authority. The licensing authority has decided that this drug is safe for use. Okay? What the SMC looks at is about the clinical cost effectiveness. Okay? Is it cost effective? And if the answer is yes, it will make a recommendation that it's used within NHS Scotland. It's to try and reduce postcode prescribing. Because at one point you would have Lothian Health Board saying no, Glasgow saying yes, Highland saying no, Grampian saying yes, whatever. And it meant that people down the street from each other would or wouldn't get something depending on where they lived. So this was an attempt to remove that. So basically, new drug comes to the market, SMC will look at it and will give us its advice. And you can go on to the website and it will tell you which drugs it's looking at currently and what all the current advice is. And you can go back historically and look to see what the advice has been. And sometimes the companies disagree and they'll resubmit evidence and the advice will be changed. Okay. And it does look at the comparative cost effectiveness. And if there are several drugs out there already which are more cost effective, then they will say no, because there's already X number out there. So what happens is the SMC give us their deliberation, and then that goes to something called an ADTC, which is an Area Drug and Therapeutics Committee, who build the formularies for each area. So in our case, in Glasgow's case, it would go to the Glasgow ADTC, and they would make the decision as to whether that drug then goes into the Glasgow formulary. And generally, if SMC says yes, Glasgow will say yes. But which bit of the formulary it goes in will depend. So we have this thing called the preferred list, which in some areas is the whole formulary. Okay? And it's a more limited list of medicines. And I'm not just talking about eyes here, I'm talking about everything. And there is an eye section which just has eye preparations. And we would expect, in Glasgow anyway, that IPs would still prescribe from the preferred list. Just because you're in the community, there's no difference. We would expect you to prescribe from that preferred list, just like we would expect the ophthalmologist to prescribe from the preferred list, just like we would expect the GPs to prescribe from the preferred list. There's one list. It's not a special list for any particular type of prescriber, not within Glasgow anyway. Okay? So we have this preferred list, and again, that should be about 80% of your prescribing should be from that list and should cover most people. And then we have this thing called the total formulary. And that's basically everything else that the SMC has said yes to, and there's usually restrictions on when you would use that. So we would expect you to use the preferred list first. If that didn't work, go to something in the total formulary. And you shouldn't need to prescribe anything else because there should be something either in the preferred list or the total formulary which will treat that condition. So we should never really see you using anything that's not in either of those two in Glasgow. Okay. And everything else is called non-formulary. So if the company haven't made a submission, or if the SMC has said no, it goes into non-formulary. And we would not expect that to be used within Glasgow. And it's the same for other health board areas. Okay? We have a non-formulary process where we monitor non-formulary prescribing. So if you make a recommendation or you prescribe a non-formulary medicine and then ask the GP to continue that, right, the GP will flag this up to us, okay, in Glasgow EMU, because we are looking for outlying behaviour. So why are you recommending that non-formulary medicine? Do you just not realise it's a non-formulary medicine? Have we not given you the correct information, therefore you're just doing it by mistake? Or is it something that you are deliberately choosing? And if so, why? And if you're not happy about it being non-formulary, well, you can make a submission to get it in the formulary. Okay? So the GPs are asked to fill in this form, and it all gets collated centrally. And if a hotspot appears, one particular prescriber appears, then that prescriber is talked to, is asked to give the reasons why. Like all the health boards, we have our own prescribing website. That's ours. We've also got an app for your phone now, which has recently been launched. Anybody can download it. It has links to the formularies, it has links to the guidelines. I'm sad, I've got it on my phone. And you can go in and check if it's in the formulary or not before you prescribe it. Okay? There's obviously people like me that you can come in contact with. If you work in Glasgow and you want to know who your equivalent person in Glasgow is, I can find out for you and tell you who it is. And I'm sure in the other health board areas there will be similar people that you can get in touch with. And that's what we're aiming for. Nice, healthy eyes. And that's me. It will just very much depend on your GP. And again, a lot of GPs will just say, well, you're the specialist, you've got more specialist knowledge than I have, therefore I will accept your recommendation. You'll get other GPs who'll go, no, that's not in the formulary, therefore I'm going to try the formulary preparation first. You know, they will say, okay, I accept you've diagnosed whatever. I will then use the formulary preparation first, and if it doesn't work, then I'll move to the non-formulary or whatever. But that's going to start happening increasingly. There's only 23 prescribers within Glasgow at the moment that are qualified and are registered, and fewer of them are actually prescribing. So at the moment it's very patchy. There's hardly any activity going on. But as more of you qualify and as more of you prescribe more, you will get more activity happening. And certainly within Glasgow you're going to start, because I'm leading on it, so I know it's coming because it's me that's making it happen. And like I say, I'm meeting Janet Pooley next week, I think, or the week after, and we're looking at national stuff as well. It probably will just be once a year you'll get a report saying this is your prescribing. In Glasgow, the plan, and again I can only talk for Glasgow, is that the person like me in your area plus the lead optom for your area would probably come out and chat to you about your prescribing. We're also in Glasgow trying to organise a peer review event, trying to get everybody together so we can talk about this sort of thing, so we can feed back the information. What are you actually prescribing? Why are you prescribing it? Can we tease that out? Can we talk about it? And also so you can learn from each other. And you can say, oh, well, actually I tried that and it didn't work, and I'm really nervous about using that. Why? Well, I had this bad experience, you know. We've all, well, maybe you haven't yet, but you will have an experience where you prescribe something and you have a really bad reaction, and that makes you more nervous about prescribing that again. It definitely happened to me. But you learn from that and you take it on board, and you're just that wee bit more cautious the next time you prescribe it. So that's happening in Glasgow. I can't speak for all the other health boards what will happen, but I suspect it will be something similar. And I don't know about England. I suspect they'll have PCT and PCTs, people sitting like me, who will no doubt come out and want to speak to you about your prescribing. If your prescribing's completely formulary and you only ever prescribe, you know, Celluvisc or something, the chances are we'll just send you a report and say, there you go. It'd be the oral antibiotics is the thing that will get most people excited, because I know you do prescribe oral antibiotics occasionally. There's not a lot of guidance out there for the use of them in eye conditions, so therefore people would come out and ask you why you're prescribing that. And I know, is it blepharitis? Yeah. You might use it in that. But even then I was just looking, and the college has just sent something out in July. And even then it says the evidence is very weak. And therefore really, if you're prescribing a lot of that, I would be coming out and saying, why are you prescribing a lot of this? Maybe you don't realise, but if you prescribe an antibiotic for somebody, they immediately get resistance to that antibiotic for at least the next month, probably the next 12 months, which means if you give them it for blepharitis, they then get another infection of some description and they go to the GP gives them the same antibiotic, it won't work, and therefore they'll end up getting a second antibiotic. And as I said, we are trying to reduce the amount of antibiotics in the community in total. And therefore, I mean, to me it seems to be lid hygiene and maybe chloramphenicol seems to be the sort of treatments of choice. Well, we need to educate the GPs. And that's exactly what I would do. I would go to the GP and say, why did you prescribe that? That's not in the guidelines. We would challenge that. And we do all the time. They're all online. They're all, the only one I couldn't find online was Borders, Scottish Borders. But I got it, I emailed them and they sent me it. So that was the only formulary in Scotland that I couldn't find online. All the other formularies are online. Well, off licence, you're taking the professional responsibility for that medicine. So if something goes wrong with that patient's treatment, the manufacturer will just say, well, we don't recommend it for that particular instance. The legal responsibility lies with you. So be careful if you're using unlicensed preparations. And some of the preservative-free ones are unlicensed, what we call a special. They have to be manufactured particularly for a patient, okay? People who are serial offenders, we don't have a lot of ways of retribution, as it were, apart from us coming and moaning at you a lot. I've only once seen a GP who was a serial offender being asked about his contract, because the contract, certainly for GPs, I don't know if it's in the optometry contract, it states you must be cost effective in your prescribing, or you should be cost effective. And if it's blatantly obvious that you're not, then it could be, and that was kind of the way it was starting to go, but the GP decided to start behaving instead. It was easier. So there isn't an awful lot of cannons we can get out and shoot at you or anything, but we will come and annoy you a lot and moan at you a lot. I go to our locality group, our GP locality group, and we take graphs with us, and none of them want to be that one up at this end of the graph, because that means you're an outlier. And we used to do it all anonymous, but we got agreement from everybody that we would de-anonymise it, so everybody knows who everybody is. We're going to do it anonymous for the optoms to... yes? Initially, anyway. Because you know what happened? We would all sit there with the anonymous A to Z or whatever, and they'd go, which one am I? And I'd have to sit with my chart going, right, you're D, right, you're F, and it got silly. So we got to the stage where we all agreed that I would just put it on, and then they all knew where everybody was, you know. You are quite isolated, you are quite, you know, because you are independent and working in your own areas. So hopefully we can help you, you know, keep up to date, understand what's going on, and if you are doing something that is a bit unusual, we can highlight that to you and give you an opportunity to think, well, maybe not, maybe I should change my prescribing back to where everybody else is going, you know. But if you've got a special interest, you particularly prescribe for, I can't remember that condition, anterior uveitis or something, is that correct? Is that a condition? And you use corticosteroids for that, yeah? So actually for me, from a pharmacist point of view, I would be going, oh, there's an awful lot of, why? And there's a very good reason why. Okay, but if it's not common, you'll stick out. And so we'll come and ask you, and then you'll say, oh, well, I'm a specialist, I've done extra training, therefore this is a condition I would normally treat. It's within your scope of competence, that's absolutely fine. And actually, in time, I'll get to know that you're a specialist, and I'll not worry about you being an outlier anymore, because I'll know that that's why. And we do that with the GPs. We've got some GPs who are diabetic specialists, so their diabetes prescribing is off out here compared to everybody else's, etc. So you get to know the specialisms of the prescribers. Well, you tell me. How many times has the reps been in to see you? Do they leave you stuff? Do they invite you to educational events? I would always just keep at the back of my mind, why are they doing that? And they're only doing it for one reason, and they're doing it because they want you to prescribe or recommend their product. Now, I don't have anything against the pharmaceutical industry. We need them. We need them to produce new drugs, better preparations. But they can be, well, their marketing can be very interesting. They will tend to concentrate on whatever number makes theirs look the best. And actually, if you look at the evidence, it might not be quite as clear-cut as they might be, because they might just fail to mention other bits. So, by all means, but be objective when they're presenting you with their information, because they do have a job. They have a job, and their job is to sell their product. And you know what? If they come up with a great product, it'll get put in the formulary, it'll get used, And so we do need them, but just have that little bit of cynicism at the back of your mind as to, well, why are you doing this? You're doing it for a reason. Why are you buying me a sandwich? There will be a reason. And the reason is because they want to sell their products. So I would just be a little bit cynical and a wee bit sceptical when information is being presented to you, and go away and do your own research, and you'll probably find that it's not quite as clear cut as they've made out. And if you are struggling, come and speak to people like me, and we'll help you. If you stick to the formulary, pretty much we've done the work for you. The SMC and us, we've done the work for you, and therefore you don't need to worry about it. But obviously, as new products come on, and quite a lot of the eye products, the companies have chosen not to put a submission to the SMC, and therefore we cannot put it in the formulary. Even if it was the best thing since sliced bread, if they don't do that, we have a process, we cannot recommend it. So, if the rep's coming in and saying, oh, this is the best thing since sliced bread, but they haven't done an SMC submission, then really what they should do is do an SMC submission, because then it would go through the process and very likely end up in the formulary. And then the volume would go up because we'd recommend it and it would get used. Yes, we've only just done it. Frank was on the group. Hugh was on the group. We had ophthalmologists there, I was there, and we've just reviewed the entire section. It's going through its approval process at the moment. So we looked at all the evidence, we produced a short list, we made the selections, or the recommendations. It goes to this ADTC, this Area Drug and Therapeutics Committee, who should rubber stamp it, and then it'll go into the formulary, that'll be on your app, that'll be on your phone, and so those products will change. We're taking hypromelos away as being the first choice, because we listen. So it's not a case of, I'm not an expert, so if you tell me that hypromelos is not the best thing, although why do we prescribe so much of it? That's what confuses me. Mind you, if you convert every one of those hypromelos to something else, then our costs would probably triple. So you've got to be careful. Because if we suddenly switched everybody from one to the other, we couldn't afford that. And that's just me being honest. The budget would just get blown. And then we would be in those difficult situations where we're saying, right, which drugs do we give people and which drugs do we don't? And we don't really want to be in that situation, because we have a fixed amount of money. And there's only one amount of money for the whole of Scotland. That gets taken into account in terms of cost effectiveness, certainly for like other drugs. So we'd say, right, how many visits or how many times a day do you have to use that? How many DN visits would you need? How many, all of that thing does get taken into account. Although it's all different budgets, it's still cost effectiveness. But at the end of the day, we've got X billion pounds to spend on prescribing. And if suddenly we start prescribing this drug that costs more than the one we used to prescribe, then we're in trouble. And that's just a fact of life. And it happens all the time. And then sometimes we're lucky because something will go on, become generic, and the price will plummet. And we get a bit of breathing space because that cost has come down, which means we can now afford these more expensive ones for a wee while anyway. So it does go in swings and roundabouts. The problem is we know we don't have any big, like Losec coming off patent and going generic for a few years. So we know there's real pressure on. And all these new drugs are always vastly more expensive because the companies need to make their money back. I mean, we understand what they're doing and why they're doing it, but it just puts huge pressure on the prescribing budgets. So even your bottle of Optive, I don't know how much a bottle of Optive is, £3 or £4 or something for the NHS, and a bottle of Hypromelos is like £1. So if you convert every bottle of Hypromelos to an Optive, then you're talking about a 3-4-fold increase in costs. So we would be saying, well, what do we cut back in order to be able to afford that then? What else can we save somewhere else in order to be able to afford that?